3 series, which is essentially evidence, experience, and expertise. This is something which I've been taught of for many years, where we try to relate the evidence along with the experienced colleagues. So, for this, we have got 2 parts in this. The first part is going to be people telling about evidence. The second part will be the senior surgeon telling about their experience. So the theme of today's talk is going to be advancement in ACL reconstruction, for which we have got Dr. Bharath, who is from Mitra Hospital in Bangalore. He's a consultant and director over there. And then Dr. Naveen is from Raichur. He's a consultant over in Saran Bashveswara Hospital, Raichur. He's a consultant over there, and he's also associate professor at Navodaya Medical College. Welcome, Naveen. And then now Dr. Prajwal Ganesh, who is a consultant orthopedic surgeon at Thiruvannamalai. Welcome, Prajwal. So welcome, Bharath, welcome, Naveen, and welcome, Prajwal. And then in terms of experience-wise, we have 2 star speakers. One is Dr. Himanshu Kataria, who is heading the Sports Injury Center at Safdarjung Hospital in New Delhi. Welcome, Dr. Himanshu. And then I have Dr. Amit Chandratreya, where they call it Mr. Amit Chandratreya. Hello, Amit. And he is from UK. To my knowledge, you would have done thousands of ACLs, and very experienced surgeon. And he consented to share his experience in a short notice itself. I'm very, very happy about it. Thank you, Amit, for joining us. He's working in Princess of Wales Hospital in Bridgend in United Kingdom. Thank you for joining, Dr. Amit. And I wish to thank all the delegates for joining here. And a lot of delegates I know very well. And individually, I want to thank everyone and all those going to watch the program. And I want to thank the OrthoTV team for channelizing our program. Thank you very much, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and also whole team, Poonam. And I thank Sun Pharma Group for helping us to organize this program. Veera Raghavan and all your colleagues. Thank you, everyone. With this, we don't want to waste too much time. Let's go on to the scientific program. And the program is supposed to be like 10 minutes of each for evidence talks. For experience, it's going to be 15 minutes of each. So hopefully, I want all the speakers to try to finish in time so that we can have some fruitful discussion at the end also. Okay. So with this, we'll start the program. Let me start with Dr. Bharath. Are you ready, Bharath, to share your screen?
Yeah.
And his talk is going to be on best graft for ACL, what the literature says.
Can you see my screen, sir?
Yes, we can see it.
Okay. So today's talk, we will be talking about best graft for ACL as per the literature. So is there a gold standard or is there an ideal graft what we are looking for while reconstructing the ACL? The answer is no. There's so much of discussion as to what is the ideal graft. So criteria of an ideal ACL graft is one which recreates the anatomical and biomechanical properties of the native ligament. It guarantees the safe fixation. It provides a rapid biological integration, reduces the recovery time of the patient from the time of the surgery to the time of complete recovery, that is going back to sports. Donor side morbidity should be the least. It should be adequate graft length and the whole surgery should be cost effective. The ACL graft has undergone a lot of changes. The first documented ACL tear has been in the year 1845. But the first surgery where an ACL graft was used was the fascia lata, was in the year 1917 as per the literature, following which there was a wide gap and in 1934 was when Friedman used the semitendinosus and the gracilis graft, and in 1935 quadriceps tendon graft. Later in the year 1963, bone patella bone graft was used. What is the criteria for ACL graft selection? Biomechanics of normal ACL and ACL graft should be maintained, but all the grafts which we do take have a much greater tensile strength than the native ligament. And the biological healing of all these grafts has been divided into the number of weeks they take to integrate into our cells. The bone patella tendon bone graft takes at least 6 to 8 weeks for integration. The quadriceps tendon autograft takes about 8 to 12 weeks. The hamstring grafts take about 12 to 16 weeks, and the allografts take minimum of 12 months. The ease of harvesting these grafts. Hamstring among all of them is the easiest and the fastest to harvest, but the learning curve also is challenging. It is easy to cut the graft while using the stripper. Next is the quadriceps, and the bone patella tendon bone autograft is the most difficult among this.
The weight loss treatment.
The is surgeon dependent, and the lack of objective evidence is the decision criteria, because there is no fixed rule as to when are we going to allow the patients to go back to play. Whether they are athletes or whether they are recreational players is what determines that. Donor site morbidity. Bone patella tendon bone autograft has the highest amount of complications, then compares to the quadriceps tendon autograft and followed by the hamstring autograft. The donor site complications very commonly we see is fracture of the patella in an inexperienced hand, anterior knee pain, which is very common, nerve injury with hamstring harvesting. So the biomechanical properties, when we consider, an intact ACL has an ultimate strength of 2,160 newtons, and the stiffness is about 242, and the cross-section area is about 44. Now, comparing these grafts, the bone patella tendon bone graft, the quadrupled hamstring graft, and the quadriceps tendon, all of them have a much higher stiffness and strength than the native ACL. Now the question now is, are we giving them more stiffness and more strength to compensate? And how are we going to achieve the intact ACL into integration into the normal knee joint? Now coming to the autograft results, the bone patella tendon bone graft versus the hamstring grafts. In this study, which has been published in the year 2011, it was a level 2 systematic review which demonstrates that there is no difference in major clinical results between graft types with the exception of increased anterior knee and kneeling pain. There is another study which has been done later in 2017, which shares that it's a meta-analysis of a short to mid-term follow-up after primary ACL reconstruction. Hamstring autografts failed at a higher rate than the bone tendon bone autografts. However, the failure rates were lower in each group. The difference observed was small and can be negligible. And we observed few differences between the graft types in terms of laxity. Now, comparing between the hamstring versus the quadriceps tendon graft, a 6-strand hamstring tendon and quadriceps tendon graft had similar biomechanical properties with respect to ultimate load to failure and load at 3 mm of displacement in cadaveric specimens. But both grafts were significantly stiffer than the native ACL, and the hamstring tendon construct was significantly stiffer than the quadriceps tendon. But this whole study was done on cadavers. Now, in comparison to that, a level 4 study, which is done between hamstring and quadriceps tendon, showed that on surface electromyography, it was found that the quadriceps tendon group had increased vastus medius obliquus activity of the treated legs. Now, if you compare all the 3 grafts, The quadriceps tendon autograft had comparable graft survival as compared to that of the bone patellar tendon bone graft and hamstring grafts. However, donor side mobility was significantly lower with quadriceps tendon autograft and the hamstring autograft, followed last by the bone patellar tendon bone graft. And the cross-sectional area of the quadriceps tendon was twice that of the hamstring and 1.5 times more than the bone patellar tendon bone graft. Now, coming to the ultimate load to failure and stiffness were significantly higher for the quadriceps tendon graft. The variability in the cross-section area was similar in all three tendon groups. Now, what happens when you have so much of confusion among all this is that which graft are we looking at ideally to fix for the patient? Now, comparing all these three grafts, if we take the bone patellar tendon bone graft, the bone healing is at 6 to 8 weeks. Initial fixation we can do with interference screw. Morbidity is large because they have a large incision. Also, the amount of ease of harvest is difficult in comparison to the hamstring and the quadriceps tendon graft. Now, the hamstring graft, which is most commonly used by most surgeons, has a period of 8 to 12 weeks, up to 16 weeks is the biological incorporation period. Now, the initial fixation is variable. It is completely based on what the surgeon prefers. It's a smaller incision and less post-op pain, and it is debatable. Now, quadriceps tendon graft, the question over here is, are we taking a piece of the patella also along with it, or you're not taking a piece of the patella along with it? When taking the piece of the patella along with it, the chances of tendon healing and bone healing is much more rapid, as there is a bony component to it. If it's only a tendon healing, again, it can go up to 12 to 16 weeks. Initial fixation is variable, and possibility of mobility is less than that of the patellar tendon, and the ease of harvest is debatable. Now, there is a question, why not use allografts? But there are pros and cons for using an allograft. The graft strength, the size variability, smaller incision, and less post-op pain has the advantage of the allografts, while the chance of risk of infection, slower healing, cost, and availability. Availability is a big question in India with the situation of not having enough number of cadavers for the amount of ACL reconstructions which we are doing. So in summary, bone patellar tendon bone graft allows incorporation into the bone early compared to the other two, and therefore can go back to sports early, keeping in mind the morbidity of the donor side. Quadriceps, as per literature, is the second best graft after bone patellar tendon bone graft. Quadruple hamstring graft gives the highest strength and stiffness, but time to incorporation is longer. So, as per literature, for an athlete to return back to sports, the ideal graft is a bone patellar tendon bone graft, followed by quadriceps tendon, followed by hamstring. But for a recreational player who does not have enough amount of, who has enough amount of time for recovery, hamstring would be the ideal option, followed by the quadriceps tendon and the bone patellar tendon bone graft. Thank you.
Thank you, Bharath.
Thank you, sir.
Any questions anyone has got? Nothing has come in the chat box. I mean, but Bharath, one word answer for you. What will be your choice of graft?
Sir, I was using a lot of hamstrings, but now I've shifted to quadriceps tendon because I found much better fixation and much better recovery at a faster rate. So I shifted to quadriceps tendon graft now.
Okay, fine. Yeah, I think biomechanical studies have shown. One thing you quoted is 6-strand hamstring graft is equivalent to quadriceps. But 6-strand hamstring graft is very difficult to get it, isn't it?
That's only an all-inside technique where maybe we can do a 6-strand if you're doing an all-inside. Because according to that study, it shows the all-inside technique they've used for that cadaver study.
Okay, fine. I mean, if there are no questions, we'll move on to the second talk. so that at least we'll discuss everything at the end if you want. Yeah. Dr. Naveen, are you ready to share your screen?
Yes, sir. Yeah.
Please, yeah.
Yes, thank you.
Naveen is going to talk on tunnels in the ACL, which is, I think, the most important of ACL surgery is tunnel position only. So, which he has done a lot of literature research about it, and he's going to share his whatever he's learned in the tunnel positioning.
Good evening, sir. Good evening, everyone. First of all, I would like to thank Dr. K.N. Subramanian, sir, for giving me an opportunity to be a part of this webinar. So my topic for today's webinar is tunnel positioning for ACL, what the evidence says. If you look into whole ACL reconstruction procedure, the most important and crucial step is the femoral tunnel preparation. So this study by Masroof showed that the poor positioning of the femoral tunnel is one of the leading cause of ACL failure, which constitutes around 50%. So coming to evolution of the ACL femoral tunnel, which way back in 1990s, we started with a transtibial endoscopic technique, which resulted in a placement of tunnel, which is very high in the notch, and the graft position was very vertical, which resulted in a high failure and early osteoarthritis. Various biomechanical studies by Lim et al. Driscoll showed that the anatomic position of the tunnel is better than a non-anatomic position, thus placing the graft in the center of the footprint, which restores the anterior, posterior, and rotational stability than a vertical non-anatomic grafts. So we shifted from isometric position to anatomic position, which was kinematic studies, which was done by Victor Marshall, showed that the femoral tunnel position inside the anatomical footprint of the ACL results in a knee kinematic, which is closer to the intact knee. So we shifted from the isometric to anatomic, which was propagated, that is anterior ACL reconstruction, which was proposed by Freddie Fu et al. From University of Pittsburgh, who showed the anatomic ACL reconstruction through anteromedial portal technique, where we used to recreate the ACL tunnel within the ACL footprint, and thus the tunnel was shifted from high to low or shallow. So this is a systematic review article published in Arthroscopic Journal by Pfeiffer et al., which showed this is the anterior, this is the posterior, this is a proximal and distal. When we see through arthroscopy, it's the knee in 90 degree of flexion. So the position of the ACL, center of the ACL footprint is around 43% posterior to the proximal, from the proximal border of the articular cartilage. That is, it is located at this point, and it's roughly 2.5 mm from the posterior articular margin. This is a systematic review which is published by Zhu et al., which showed that the femoral footprint location is the single bundle ACL reconstruction. The center of the footprint is around 50% from the proximal articular margin of the from proximal articular margin to the distal articular margin, it is around 50%. The green arrow shows the standard area of ACL tunnel, and red dot is the theoretical center. This line is parallel to the femoral axis of the femur. The study shows that if you go for a double bundle technique, the AM bundle was at 31% from this A, that is the posterior proximal part of the articular cartilage margin, and PL bundle was 66%, that is 31% and 66% from the posterior articular cartilage margin. What are the concern when you do an anatomic ACL? It usually resulted in a high forces on the graft when we put the tunnel in lower position, which was being studied and published by David McAllister. So this was a study published by Freddie Fu, who showed that after anatomic ACL reconstruction with allograft, they showed there is a 13% failure rate after 2 years, which is more with a double bundle ACL reconstruction. So this was a study which was published in Danish registry, which showed that if we create a anatomic the femoral tunnel through anteromedial technique, the chances of risk of failure are high as compared to transtibial technique. But the author concluded that it is because of two things. One is because of complexity of positioning the tunnel through anteromedial portal, and second is because of the high graft tension around the graft, which resulted in increased failures. The anatomy was revisited by Robert Smigelski, who introduced the ribbon concept of ACL anatomy. He showed that the ACL is a flat insertion rather than a bundle. It has a stout band of fibers at the ridge, that is, and the intercondylar ridge, and a wispy posterior extension, which was further supported by this study by Sasaki. It's a histological study where they showed the ACL fiber insertions have two types of fiber, that is a direct and indirect fibers. The direct fibers which are marked in the black area. These are directly inserted into the lateral intercondylar ridge, and the expansion is marked in the red area, which is the indirect fibers. So the biomechanical study by Nawabi et al., which was published in Sports Journal Medicine, which showed that within the anatomic region of ACL femoral footprint, the high ACL fibers, that is the direct ACL fiber inserting on the ridge, carries the greatest load, that is 80% during stability exams, and they are more isometric during range of motion. So this is what they say. These are the fibers which, this is the area where the high ACL fibers getting inserted on the ridge, and it supposedly has a higher biomechanically prone results. This is further substantiated by this study by Kawaguchi, which showed that 80% of the resistance to anterior tibial translation was from the fibers which are inserted into this area, that is a central and proximal area of femoral attachment, that is a blue dot circle, and the other fan-like extension fibers contributes less to the anterior tibial translation.
Naveen, 1 second, can I interrupt if you don't mind? Naveen?
Yes, sir. Yes, sir. Yeah.
The slide is going in the presenter mode. See whether you can convert into the display mode.
Sorry.
It was going, you can see two slides together like that. It's a presenter mode.
Yeah, I got it. This is fine, sir.
Start sharing again.
Yes, 1 second. Is it fine?
Thank you. Yeah.
Coming to this study, which is 1 second, sir. There is one technical glitch.
Just click on the slide and move ahead.
Yeah, we're just going there. So this was a study by Kawaguchi. What I said, it showed that the fibers which are present on the central proximal area constituted for a higher biomechanical strength for the ACL. So with this background, the study article published by Andrew Pearl showed a new technique which is called ideal femoral tunnel position. They showed that the tunnel should encroach on the ridge, it should be anatomic, but it should be in the most functional position of the footprint rather than in the center. It should be should be created in the most functional portion of the footprint and should cover the direct fibers which are present along the ridge of the along the intercondylar ridge, and it should optimize the isometry, thus reducing the tension. So the tunnel was shifted from shallow to the center. With this study or technique was further evaluated and published by Su et al., showing that the clinical outcomes are good and they advise for further study of this technique. This is a recent article which was published in BMJ by George et al., which showed that author tells that the tunnel position occupying the larger anteromedial area of ACL origin and closer to the lateral femoral intercondylar ridge will usually result in better functional outcome and it reduces the failures. This is a concept of functional anatomical reconstruction rather than anatomical reconstruction. It is a functional anatomical reconstruction. It is of great value because, as we know, we can't recreate all of the diameter of the ACL footprint insertion. So the technique seeks to reconstruct the ACL at its most important, most functional position rather than in the anatomically most central portion. So coming to tibial footprint, so this is a systematic review by Hong, which showed that the ACL tibial footprint center is 15 mm anterior to the posterior cruciate ligament, and it is 2/5 of the interspinous distance. This is the center of the ACL. If you see for bundle, this anteromedial bundle is located 20 mm anterior to the PCL and 1/4 of the interspinous distance. And the PL bundle is located 12 mm anterior to the PCL and it is halfway in the interspinous distance. There are two other landmarks which were being described by Mari Ferrati, the cadaveric study, and they show as the anterior horn of lateral meniscus is not a good landmark because it has a variable relationship with the ACL tibial footprint. So they studied and given a two anatomical landmark. One is the intermeniscal ligament, which is the posterior quarter of the intermeniscal ligament. The center of the ACL tibial attachment was 9.2 mm posterior to the posterior edge of the intermeniscal ligament. This is the ACL tibial footprint center, which is almost 9 mm posterior to the and posterior edge of the intermeniscal ligament. And similarly, they suggested a bony or osseous landmark, which is the peak of the medial tibial spine. And they suggested that the center of the ACL tibial footprint is around 5.3 mm anterior to this location or landmark. This was a study which was published by Ashish Bedi to know the effective tunnel position and its outcome. They suggested that anterior tibial tunnel position usually controls better latchman and pivot shift as compared to ACL graft placed in the posterior aspect of the tibial footprint. But they suggested that we should balance against the increased risk and magnitude of graft impingement when we place the tunnel anteriorly. This is a radiographic method which is done in a human cadaver by Chu et al. And they concluded that the center of the ACL tibial footprint is an average around 40% from the Amis-Jacob line, which is a line parallel to the medial tibial plateau. Thank you.
Thank you, Naveen.
Thank you.
I think you extensively covered. You have done some good literature search.
Yes.
Thank you.
Thank you.
Are there any questions? Anyone want to ask any questions? Or we go to the end? questions. Let's go to Prajwal. Dr. Prajwal, you start.
I'm sharing my screen.
And Prajwal is going to tell about which is the best implant to fixation devices.
Good evening, sir. Thank you for the opportunity that you have given me to present in this e-series. And I'm here to talk about ACL fixation devices, which is the best. As surgeons, we have some factors under our control: graft selection, positioning, fixation devices, and rehabilitation. And the graft healing, usually the BTB takes around 6 weeks. Soft tissue grafts take around 12 weeks. And till this time, the fixation devices should secure the graft to prevent failure. Currently, rehab protocol is very fast, as there is a demand from the patient side for early weight bearing and early return to full range of motions. So early strengthening and neuromuscular coordination is being followed at many centers. Biomechanically, reconstructed ACL is subjected to 150 to 500 Newton forces in activities of daily living. Within the first 6 weeks, the graft is subjected to around 220,000 such loading cycles. Fixation is the weakest link at the early postoperative period, as studied by Grover et al. Ultimate load to failure is about 3,000 newtons for BTB and 4,000 newtons for quadriceps graft. This far exceeds the usual forces of 150 to 500 newtons that occur during our activities of daily living. Graft motion is of 3 types: longitudinal, this is bungee cord effect; horizontal, called as windshield wiper effect, and creep in between the graft and the tissue. More than 3 mm of motion causes tunnel widening and interfere with graft incorporation, so leading to early failure. Some important definitions to be noted are strength, which is the ultimate load to failure; stiffness, the resistance to displacement under load; and slippage of the graft, the change in initial position under specific number of submaximal cycles. Ideal fixation should be strong enough to avoid failure, stiff enough to restore knee stability, and secure enough to avoid slippage. And it should be anatomic, biocompatible, safe, and reproducible by most of us. And it should be MRI compatible and allow easy revision. Coming to the types of fixation, Lambert in 1983 devised the aperture fixation at the level of the joint by interference screws. And extra-articular fixation can be either direct or indirect. Cortical extra-articular fixation was introduced by Thomas Rosenberg in 1990, and cancellous extra-articular fixation by Clark et al. In 1998. Interference fixation is the amount by which the diameter of the screw exceeds the gap between the graft and the tunnel. The interference fixation is the best possible way to get an aperture fit, and this has advantages by minimizing graft tunnel motion, less femoral canal widening, and less creep. Factors that influence interference fixation are the length, size, and geometry of the graft, the divergence of the screw, and torque during insertion, the bone mineral density, and screw material. The length, longer the screw, better the fixation. In bone tibial graft, engage the screw only to the bone plug. Size of the screw should be at least 1 mm more than the tunnel diameter for soft tissue graft and in some bone plug grafts, as stated in this study. Geometry, we should use soft thread screws for soft tissue fixation and reverse threaded screws for left-sided knees. And insertion torque, more the insertion torque, it gives a better fixation. This insertion torque is higher with metal screws and with larger diameter screws. And when the tunnel is prepared by dilation, the insertion torque is better. Tunnel dilation, usually we should underream the tunnel by 2 mm and then use dilators to dilate the tunnel. This dilation compacts the bone and rather than removing it, and increases the insertion torque. Divergence, more than 20 degree divergence compromises the stability. This usually occurs with transtibial technique of femoral tunnel preparation. PMD less than 0.6 gram square has a less pull-out strength. Attractions towards biodegradable screws is that it does not need implant removal, does not interfere with the MRI, and revision is easier. But faster absorbing or degrading biodegradable screws should not be used. So polylactides are better. The disadvantages are it may break during insertion, and it needs a special screwdriver to insert. There can be tissue reactions, and after partial degradation of the screw, the fixation is lost. By 6 weeks, 80% of the strength and 60% of the stiffness is lost. There is an incidence of tunnel widening and effusion with biodegradable screws. Titanium versus steel. Titanium is better as bone growth is better with titanium, but steel screws are only covered with fibrous tissue. Coming to the femoral fixation, most commonly used types are endo button. This is the first generation of suspensory fixation, which are fixed loop. And femoral tunnel has two parts. First is the insertion part, and then is the connection part. The insertion part is drilled to the diameter of the graft, and connection is 4.5 mm diameter for the passage of the button. And in endo button technique, the graft tunnel motion is more. So there may be tunnel widening, but clinically the outcomes are not much of difference. Tightrope is the second generation, which is adjustable loop, where the loop length can be adjusted to allow more graft to be filled into the femoral tunnel. Simplified math for the femoral tunnel drilling. Femoral tunnel length minus the desired graft length is equal to the loop length. That means if the tunnel length is 60 mm, the desired insertion length is 40 mm, then the loop should be 20 mm. But you should always have an insertion tunnel length to be 10 mm more than the desired graft length. So for a 60 mm tunnel length, the insertion tunnel should be 50 mm long. The fixation options available for femur: bone plug fixation by interference screws, which is the gold standard; suspension type by endo button; and transfixation type. The transfixation type is cancellous fixation. The bone plug fixation for the tibia is with staples or suture discs or posts and interference screws. For soft tissue fixation of the femur, the interference screws are again the gold standard. Suspension type with either endo button or tightrope, and transfixation type. Interference fixation, especially with bio screws, need a slower rehabilitation. Soft tissue fixation for the tibia is by either staples, screws or posts, or preferably hybrid fixation. The tibial versus femoral fixation. Tibial fixation is less secure as there is reduced bone density and the angle of forces are in line with the graft. Bone strength falls rapidly away from the joint. So the fixation should always be aperture and should be nearer to the joint line. Literature supporting this are one of the studies from Malaysia compares interference, cortical and transfixation, where interference fixation is more stable. Gaved et al. Revealed that in a study group of 20 patients with a bioabsorbable screws, 14 of them complained of pain and 6 cases produced a large cyst formation. Almeida et al. Among the 176 patients, the fixation with metal washer and screw, 44 of them suffered from pain post-operatively. Complications reported to the usage of endo buttons are they involve migration, iliotibial band friction, and detachment from the cortex outside the bone. Out of 202 patients of ACL reconstruction studied by May et al., 71 patients, the endo button had migrated. This is a study for the transfixation technique, where 11 out of 50 patients, the transfix was broken in follow-up MRIs. So, in general, aperture fixation provides advantage over distal fixation. Interference screws are the only method providing fixation closer to the articular surface. Take-home message is, aperture fixation is theoretically better. Interference are the gold standard. Hybrid fixation is becoming more popular, and tunnel dilation improves fixation. The early postoperative period is the weakest link. So we need to have good results even after 4 to 6 weeks, not at time 0. So tibial fixation is at a greater risk of failure and tunnel widening is a great concern. I would like to conclude this session by introducing my facility at Thiruvannamalai, Dr. Subramanian Center for Arthroscopy and Laparoscopy. This is the first keyhole center for the district. And I thank my arthroscopy gurus, Dr. K.N. Subramanian and Dr. Pratap Kumar, without whom I would not be at this point. Thank you, sir, for giving me the opportunity.
Thank you, Prajwal. Thank you very much for summarizing nicely.
Thank you, sir.
Let's see, is there any questions in the chat box? There's nothing is there. What is your opinion, bioscrew or metal screw?
I still suggest metal screws to my patients, sir.
Okay, you started seeing some issues with the bioscrews, is it?
It is not like that, but literature and mainly the graft, complications during degradation, they feel some redness and inflammatory reaction around the graft site at 6 to 8 months post-op. Some of them.
Okay, fine. That's I can't disagree also because I have also seen some patients like that. Fine. Is Dr. Himanshu around?
Yes, Dr. Subramanian. Yeah.
Dr. Himanshu, are you ready for your talk? Yeah. Can you start screen sharing?
Sure.
I think I have to just tell a couple of words about Himanshu's talk. Because of his experience, I thought he should be the right person to tell about what is the preferred technique that is being practiced. He is coming from one of the important centers in India, which is Safdarjung Hospital Sports Injury Center. And he is a director over there. Himanshu, you can start your sharing.
Thank you, Dr. Subramanian. Thank you so much for getting me into this. And I congratulate you on this novel concept of bringing in the 3 E's. So, and with such an exhaustive evidence having been provided, I feel that the presentation for me is going to be slightly more complicated, I feel. So without much ado, one very simple, straightforward thing that is every ACL tear in for an ACL reconstruction. So the way I take it, that if there is an absence of symptomatic instability, if you have a compensated ACL deficiency, the ones which we call as copers, or if you have a neglected ACL in an arthritic joint, probably no. Now, what are the goals of an ACL reconstruction and how would you actually be defining? We all know these, but the goals are to have a stable joint, to reproduce and recreate the kinematics of a normal knee, and to attain a near normal function. Therefore, the ideal reconstruction should ensure that we have a strong graft, which is correctly positioned. This graft should actually avoid an impingement. It should preserve the biology by stump preservation. And one must have a strong construct. Therefore, one must secure the weak link, and certainly one must address the associated instability. Now, this is quite a talked about topic. What would you prefer? Would you prefer isometry or would you prefer anatomy? So, in fact, the very definition of isometry is that when you actually go in for a full range of movement, there should actually be no elongation or plastic deformation. Probably this cannot happen because whenever there is a range of movement, there is no one point of the femur which can maintain a fixed distance from a single point on a tibia. Therefore, almost always elongation occurs. So I'm a strong believer of the anatomical footprint, and I believe that if you can have your tunnel positions at the right footprint areas, you can actually reproduce the kinematics much better. So now briefly just going into the steps which I normally follow, which are very standard. You harvest the graft, you prepare that. You would then go in for a diagnostic scopy and management of the associated meniscus or chondral lesions. You would go in for a tibial and femoral tunnel preparation. The preparation is done in such a way that there is a smooth graft passage and fixation, and of course, a very customized rehabilitation. Now, the graft considerations are, I prefer to use a soft tissue graft, that is semi-T and gracilis. But I kind of customize it if I'm looking at somebody who is a contact sports person, somebody who's got a significant systemic laxity, I would probably opt for a BTB. But majority of the times, I prefer to take a hamstring graft. In a revision scenario, again, I would prefer something like a BTB or maybe the peroneus graft. Now, there are various ways in which one can give an incision, but I prefer to give the oblique incision, and there is enough literature to support the oblique incision. I prefer to reflect the S by giving an L-shaped incision there. And I wish to convey that it is very important that one must try to make a clear-cut plane between the gracilis and the semite as well as the MCL, so that you do not do any iatrogenic damage to the MCL. Needless to say that the vinculas or the accessory bands are something which are, there in everybody. They are almost 3 to 4 bands which are there for the semitendinosus, and a fixed 2 to 3 for the gracilis. And therefore, one must ensure that one cuts out these bands. And this can be, by giving a small tug, you can actually see that you don't feel the tug at the level of the popliteal fossa, but you can actually see a free motion of the tendon at the level just proximal to the popliteal fossa. Now, there are certain graft considerations which one must take into consideration. One is the length of the graft. So I believe that if we are looking at a semite which is more than 30 to 32 millimeter, the graft can be quadrupled. Whereas if you're looking at a semite which is less than 30 millimeters, then we probably would need to triple the graft. What is the minimum graft diameter that I'm looking at? Because there are times when you would get very thin grafts. The minimum graft diameter should be 8 millimeters. And that should be the optimal, because there is enough literature to state that the graft diameter has got a direct relationship to the stiffness as well as to the load to failure. And in fact, there was an important study which kind of was a predictor for revision, when it was found that the grafts between 7 to 10 millimeters, every 0.5 millimeter increase in the graft diameter actually resulted in a 0.8 to 0.9 times lower likelihood for a revision surgery. So I believe that's a very important thing, that you should have a graft diameter which is at least 8 mm. That's a quick preview of how you would actually be taking the graft. So you need to spend a little bit of time extra on getting these vincula out of your way, so that your stripper doesn't slip into any one of them and leads to an early amputation of the graft. I think getting the vincula out, and I prefer to use naturally the closed tendon stripper in just such a scenario, makes things very straightforward. Coming over to the tibial tunnel, how would you prepare it? The evidence presented has been adequate, but I would still like to repeat what I usually tend to follow. The tibial tunnel considerations are many. You could actually go in for the inner edge of the anterior horn of the lateral meniscus. A very common followed protocol is the just lateral to the medial tibial spine. I prefer to take the ACL tibial footprint in acute and subacute cases. Chronic cases, I agree, one is not able to take the footprint clearly, but the footprint is the best landmark, I believe. And when you take the footprint, you are automatically lying lateral to the medial tibial spine. You are automatically lying at the inner edge of the anterior horn of the lateral meniscus, and you would invariably be 6 to 7 millimeters anterior to the anterior border of the posterior cruciate ligament. So as you can see here, that this horizontal line actually corresponds to the posterior border of the anterior horn of the lateral meniscus. And this vertical line is placed in such a way that it actually guides us with respect to the trajectory of the guide wire. A quick preview here of how, the surgical steps, the same steps which I have told, that this is the tibial footprint that one sees. One is now trying to see the posterior border of the anterior horn of the lateral meniscus. And you can see that we make sure that we are lying in the center of the tibial footprint. Once this is done, this is a very important step where you try and see that there is no impingement that is being created. Once you are clear with this, now you would go in for your drilling of the specific graft diameter that is required. There is a lot of literature again to support that you need not be very rampant in destruction of the soft tissues. Remnant preservation is the in thing, and there are adequate advantages. It enhances revascularization, it prevents the leakage of the synovial fluid, and the most important, that it preserves the proprioceptive input, which is actually very, very important in terms of functional outcome and patient satisfaction. Regarding the femoral tunnel considerations, there is the outside in technique and there is the inside out. So I follow the inside out, and with the inside out also there are many ways. You could go in with the eyeballing, you could go in with the offset, or you could go in with the flexible reamers. The eyeballing is done with the help of an awl or a pick to create a pilot hole. The offset is when you have a femoral offset jig, which could be, depending upon the company that you're using, it could be 6, 7, or 8 millimeters. And the basic purpose of the offset is that it tends to allow 2 millimeters posterior wall to prevent a blowout. So that's the purpose of the offset. And then for the outside in, for the inside out, you could have the possibility or the possible use of flexible reamers, particularly when you're looking at bulky thighs, when you're looking at patients where you would like to prevent hyperflexion while drilling. Now, knee hyperflexion, how much of flexion would you give? I prefer to give the optimal flexion, which I believe is 110 degrees, because that's the position where you are able to achieve an adequate length of the femoral tunnel, which is very important. Giving an acute hyperflexion definitely makes visualization difficult. So if you need to give an acute hyperflexion, it's important that you may use, instead of that, a flexible reamer, by which you can maintain yourself at 90 degrees. This figure on the far right is just trying to depict the exit point for the guide wire, that this should be ideally placed somewhere in the center of the ITB and not posterior, in order to prevent any iatrogenic damage to the common peroneal nerve. Now, whenever I'm passing the graft, once the tunnels are made, I always use the anteromedial portal to make visualization for the button adequate. So this is what I normally do. I am a strong believer of the 2-portal technique. I do not follow the 3-portal technique. So this is the position that you're seeing is the standard anteromedial portal from which you can adequately see the button going through. The idea is to ensure that you sit over the lateral cortex and you do not cross over beyond the ITB. So once the markings, if they are correct, you try to see that the markings come back to the level of the aperture, and then you go in for your shortening. So all these visualizations I prefer to do through the anteromedial portal. Then coming over to the femoral tunnel considerations, it's very important that you should have at least 5 millimeters of intact cortex for cortical suspensory fixation. So the femoral tunnel length, as I said, if we are looking at a length which is the minimum length required for a fixed loop would be 30 millimeters, because you would need 7 to 10 millimeters for flipping. Whereas for an adjustable loop, it's a little bit forgiving. So even a 25 millimeter femoral tunnel length would probably work out best. But at the end of it, my aim is that I need to seat in at least 20 millimeters of graft into the femoral tunnel. And at the same time, I need to have at least 5 millimeters of intact cortex for the cortical suspensory fixation. The graft passage should be smooth. So once you've prepared the tunnels well, the passage should be smooth. There should be no lacerations, particularly on soft tissue graft. And once you have completed your cycling, then you need to see again that there is no graft impingement. That's a very important step, because if there is any evidence of impingement, you might need to add notchplasty. Very well spoken by the previous speaker that the weakest link is always the graft anchorage. For me, I prefer for the femoral side, the suspensory fixation. Usually the adjustable loop is what I prefer. And for the tibial side, I prefer the interference screws. And these days it is the 2nd generation biocomposite screws, which I normally prefer, which are essentially the biphasic calcium phosphate with the PDLLA. Now, this newer concept, or you can say probably a concept put up in 2 different words, the aperture and the near aperture fixation. So this was a good publication which I managed to go through in Arthroscopy 2011. And it was very clear that there was an inverse relationship when you try to see the distance between the aperture versus the tip of the screw. So if the distance between the aperture and the tip of the screw was less, the tunnel dilatation at the tibial aperture is higher. So the advantage of going in for a near aperture fixation is that you can get the advantages of an aperture, but with probably a better biology. That's a quick preview of what we have discussed. So I'll quickly going through one of the cases. So normally you would go in for first your debridement of the fat pad and go for a diagnostic round. Your diagnostic round would naturally be consisting of seeing the root area for the medial meniscus, the ramp lesion, looking out for any ramp lesions, getting into the gutters, trying to probe all these aspects, and making sure that you are probing both the superior as well as the inferior surfaces of the medial meniscus, getting then into the lateral compartment and looking out for any lesions of the lateral meniscus. So if there are any lesions, they need to be addressed, whether you go in for a meniscal repair, whether you use the all inside, you use the inside out, or you use the trephinations to improve your biology because you're doing an ACL reconstruction. Trying to highlight that there is a very clear relationship between the ACL and the posterior border of the anterior horn of the lateral meniscus. And I believe this is very, very important because this actually marks the tibial footprint very, very clearly. And I'll show you at the end of this that it is very well supplemented by good radiology in the form of MRIs and X-rays. So once your tibial footprint is defined, you would go in for the insertion of the guide wire. And you would now then prepare your tibial tunnel. So at this point, once the guide wire is inserted, it's always a good idea once again to make sure that there is no impingement, because that's the time to decide whether you would do a notchplasty or not. For me, a routine notchplasty is a complete no. Then drilling for the tibial tunnel, it's always better to be gentle. It's always better to be remnant preserving. But at the same time, you need to have a balancing act. You need to create a good tunnel so that the graft passage is easy. But at the same time, you need not be too aggressive with the soft tissue component. You would now focus on the femoral tunnel. So here again, I like to emphasize that I do not use any cautery or radio frequencies. I just try to debride the soft tissues, let the biology be preserved as far as possible. I am a fond believer of the use of the offsets. I do not believe, despite so many years, in eyeballing. So I believe in using the offsets, and I still believe that by using the two standard portals, you can create a fairly good tunnel. You can still have a good amount of posterior and inferior wall which is still present. Once you've done your beath pin passage, you need to measure that. In this case, this was about 38 millimeters. And then you would go in for your drilling of the femoral tunnel by using the specified reamer as per the graft. So in this case, the minimum drilled was 25 millimeters. Then subsequently, the loop is passed, which is then retrieved through the tibial tunnel for railroading the ACL graft. I use the adjustable loop. There are many pros and cons for the adjustable as well as the fixed loop, and studies are for and against for each one of them. It's very important at this stage that one must ensure that the markings that you do at the back table are accurate with respect to the femoral tunnel as well as with respect to the femoral tunnel that has been drilled to take up the ACL graft. So once you feel that the button has crossed over, it's very important to give small tugs to make sure that there is no bungee effect. So once we are clear that there is no bungee effect. We have seen through the anteromedial portal that the button has crossed over to the lateral cortex. It's time now to get the graft into the femoral tunnel. And the graft has its marking, which actually tell you that yes, your 25 millimeters as marked is now into the femoral tunnel. Once you believe that the femoral tunnel is fully occupied by the area drilled by you, it's time to check that you're not doing any impingement and there is no need of a notchplasty. After this, we would naturally go in for securing the tibial fixation. And at the tibial side, I almost always do an aperture fixation. Once this particular part has been finished, it's very important that you get all the debris out from the joint, because the presence of debris at any of these areas, there are so many areas, right from the suprapatellar pouch to the gutters, to the medial and the lateral gutters. So once the debris is cleared, it's only then that you can be sure that you're not looking at any subsequent postoperative synovitis. So I make sure I spend good time in clearing the debris out. I'm a fond believer of capsulotomy. I have seen that once the capsulotomy is done, the persistence of the postoperative swelling is much reduced. So we do a capsulotomy just to the point where we are able to see the quadriceps. And there are times that when you just try to go over to the lateral gutter, you might actually be seeing the button seated nicely on the lateral cortex, as you can see here. So that kind of completes your ACL. And that's the kind of position that you're looking at. So you can see here, that's the kind of X-ray, a fairly well-placed deep and inferior femoral tunnel. And on the AP view, again, you can see here a well-placed deep and inferior femoral tunnel. This is not the MRI of this particular case, but this is an MRI which is planned for a revision, which was done as a primary at our center 2 years back. So you can see that the tunnel placement was fairly anatomical. That's the tibial tunnel, and that's the T2 sagittal. You can see fairly well-placed tunnels. And that's your tibial tunnel again in the coronal views. Again, the T2 view, fairly well-placed. And that's your tibial tunnel. So the key points which I wish to highlight are that you should have a meticulous and respectful graft handling. Your aim is to replicate the native ACL insertion site. Therefore, you need to individualize the surgery. Correct tunnel position cannot be overemphasized, and you need to have a smooth graft passage. You need to have a secure fixation, and therefore you should be familiar with all fixation options. You need to treat associated instabilities, and needless to say, patience, perseverance in practice. Thank you.
Thank you. Thank you, Himanshu. Some few interesting points we have seen through. Let me see the chat box. Himanshu, can you hear us?
Yeah, I can hear you.
I think Dr. Bharath has asked about this capsulotomy. You do it regularly for all the patients.
Yeah, I do a capsulotomy in almost all my cases.
And rationale behind it?
The rationale is it basically helps to it's a closed compartment. You try to redistribute it, And the protocol that is followed post-operatively is that they are almost immediately put on static quads exercises. So whatever minor fluid that is left tends to get resorbed at the level of the quadriceps. And I have seen that till about 4 years, 5 years back, when we were not doing capsulotomies, and when we started doing capsulotomies, the incidence of the persistence of post-operative swellings has reduced significantly.
Okay, right. So essentially, you are shifting a fluid from the intra-articular to extra-articular so that will get absorbed easily. Yeah?
Exactly.
Yeah.
Sorry, you can stop your screen sharing. Thank you, sir. Thank you, sir.
And there was one more question about tunnel positioning, 1 or 2 o'clock. I think Amit has answered it. Usually, nowadays we are not going to the clock position anyway.
So I'm not very. I was a firm believer of the clock position, but I'm not too much of a firm believer anymore, because I think we are all aware the moment you change your portals, the clocks change. So I think it's a good idea to go with the footprint concept, which seems fairly anatomical.
Correct. Yeah, because one has to understand that ACL is not a very vertical structure. It's a slightly horizontal structure. A normal ACL looks like a slightly horizontal structure. So clock position is a very old concept, and we don't follow that anymore.
Exactly.
I think due to the time, we'll go on to the next talk. Dr. Amit. Amit, are you online?
Yeah.
Yeah. Are you ready? Sorry, we are running a little bit late. Sorry. Yeah. If you're ready, please start sharing your screen. And Mr. Amit Chandratreya is going to tell about what really matters in ACL reconstruction. So that is like a point which is going to tell your success. That's what he's trying to say.
Can you hear me?
Yes, we can hear you. Please go ahead.
Thanks very much. Thank you, Subra, for asking me to participate in this, what appears to be an excellent series. Sorry, I've got a bit of a sore throat, so I apologize for my voice. I think most of the topics have been covered, so it's making my life a bit easy for this talk. I work at the Princess of Wales Hospital at Bridgend in South Wales. It's a beautiful part. So greetings from Wales. I've been a consultant at the University Health Board Hospital past 16 years. We are an ISACOS teaching center, and I also have a senior clinical fellowship scheme sponsored by the Royal College. So I've been doing ACLs for a long time. I was just remembering when I first saw my ACL, and that was when I was at Sancheti Institute as a registrar 21 years ago, and we did an ACL reconstruction using BTB with Dr. Arora and Dr. Nirbhay Shah. And then we put the patient in plaster. So that definitely made his knee very stable. But that's how we have evolved over the last 20 years. In the UK, we are very fortunate to have a National Ligament Registry, and the steering committee of the NLR produces an annual report. And I'm happy to share some of the findings from the annual report. So since 2013, the NLR has been in place, and about 12,000 patients have registered into this registry. This gives us a very strong data of what's actually happening in the UK, and then how we can extrapolate it to our clinical practice. In the UK, football and rugby are the main causes of injuries for ACL, such as twisting and non-contact injuries, followed by skiing, and the rest of these sports follow thereafter. But these two are the main reasons we get ACL ruptures in the patients. Over the past 6 years, we have looked at what is the average time from injury to ACL reconstruction, and that remains at around 167 to 180 days. And the reason for that is varied. It's because of the NHS waiting list, because of the delayed diagnosis, and also because initial treatment of non-operative or conservative management for some patients. But the exact reasons are not known. The registry also gives out that almost 12,000 autografts are being used rather than allografts, and direct suture as making a little appearance in acute needs, especially in the pediatric age group. If you look at the graft diameter in this patient of almost 10,000 patients, the graft diameter is 8, which was referred to by Dr. Kataria as well, that seems to be the ideal, although the graft ranges from 6.5 to 10. The hamstrings and the gracilis graft is the most commonly one used at the moment. The semi-T used as an all-inside technique using various companies' devices, and the patellar tendon and cords make up for the rest of the grafts that are being used. Most surgeons are using the anteromedial portal. The all-inside technique is being used and is increasing slowly. A lot of surgeons still use the transtibial technique of drilling through, which in its place is still good as long as you make the tibial tunnel in the correct position. What are the fixation devices being used in the UK for the femoral side? In 2013, there was a mixture of interference screw and suspensory. This has now recently increased in the suspensory for the femoral side, but a few surgeons still continue to use the interference screw. On the tibial side, the blue is actually the interference screw, which makes for the majority of fixation of the graft, and suspensory fixation has remained almost as a similar number throughout the years. What do? I've been an early user of the all-inside ACL reconstruction. In 2011, I was using a hybrid technique by the suspensory on the femur tightrope and on the tibia interference screw and supplementary fixation. But from 2012 onwards, I've been a complete all-inside ACL reconstructive surgeon, both on the femoral and the tibial sides. I use all 3 grafts. I use BTB and cords as well. We don't tend to use any peroneus longus grafts in the UK as far as I'm aware. I know they're being used commonly in India. And if there's a requirement for multi-ligament, then we could always use ligaments from the other knee or go to allograft. So this graft fixation and graft types have been well covered by Dr. Bharath and Dr. Naveen very nicely as to what graft size and diameter you need. So at the moment, I've now moved on to the Flip Cutter 3, which some of you may have seen. This is the adjustable flip cutter, which you drill in at 3.5, and then the flip cutter then goes up to a 12 millimeter. So you don't need to open 2 flip cutters if you are doing all inside on both sides. Just have 1 flip cutter and you can change the tunnel diameter as required. The Tightrope 2 is now a suture tape fixation device rather than a fiber wire. This definitely gives better fixation on the cortical side, and the fiber wire doesn't cut into your, the suture tape does not cut into your hands as the fiber wire. So it appears to be an advancement from the old Tightrope. I use the BTB Tightrope for the cords, tendon, and the BTB. This is the old BTB Tightrope. A newer generation has come out, which makes it threading through the graft much easier. And then I use an interference screw and a supplementary swivel lock on the tibial side when it's a complete tibial tunnel. Out of all the cases that we looked at a small cohort of patients, and this was published last year, of 141 cases with mean follow-up of 17 months, but these patients had a complete perioperative reported outcomes, both pre and post-op. And all the values in EQ5D, IKDC course increased as expected. We did have a complication rate in 16 patients. The first 4 cases of arthrofibrosis were the initial patients of all-inside Tightrope when you're tightening the implants a bit too tight than required. You really need to just position the graft into the tunnels and not over-tighten. And that's a technical tip that just make sure the graft is snug and tight and not over tight in the knee. The 8 graft ruptures were the mid bundle or the 50% reconstruction, which was shown by Dr. Naveen. And interestingly, the mid bundle was initially proposed by a lot of surgeons, and then they looked at their own results and showed that there was a high complication rate of graft ruptures. So when you read literature, you should read it with a pinch of salt, because if you change your technique, it may mean that your complication rate increases. So try to do whatever is best in your hands rather than to change unless you believe in the literature that is published. Now, interestingly, Dr. Kataria also mentions the 8 millimeter graft size. Now, my colleague at Bridgend, he leaves the hamstrings attached to the tibia, as do a lot of surgeons in north of UK and in Australia. And the size of the graft then is 6.5 or 7.5 maximum. And this has not shown, at least in our series, which we looked at, to believe to increase failure of the graft, although I know literature shows that less than 8 may increase the relative risk of revision. But this procedure of leaving the hamstrings attached can help, especially if you've got a pediatric patient and the vascularity is helped by leaving the grafts attached. We published last year also on looking at my BTB and quads tendon when I used it for revisions initially. So till up to 4 years ago, the BTB and quads were exclusively for revision ACL reconstructions, but they're now moved on to a primary quads tendon as ACL reconstruction. So the past 18 months, I've been using a quads tendon as my primary ACL graft, and we're looking at publishing this of 38 patients which are matched for age, sex, and type of graft, of 20 quads and 18 BTB, this complete matched group, using a suspensory fixation on the femur and a interference screw and supplementary fixation on the tibia. What we found that when you use a BTB or a quads tendon bone plug, and if you're using a suspensory mechanism, most of the companies will tell you to flip the button and put it on the cortex and then pull the bone plug into the tunnel. I found that in some cases, as you're pulling hard, the threads can break the bone plug. So what we now do is we dock the bone plug into the femoral tunnel and then bring the button onto the cortex. And that helps in preventing that damage to the bone plug and hasn't shown to be any cause of concern for loosening. And having the bone plug in the femoral tunnel without any interference screws gives rise to circumferential bone ingrowth and early healing. While if you put an interference screw, healing is mostly on 50% of the bone plug rather than complete bone plug. So what is the goal of ACLR? Is to provide the patient with a stable knee. And I think the previous 4 speakers have covered this extensively. So I'm just going to give you my take on what really needs to be done and what matters in an ACL reconstruction. So it is your clinical diagnosis to making sure that it is the ACL which is ruptured and you're not treating something else. You have to select your patient. If a patient is low demand, is not symptomatic, this giving way maybe once a year, then do consider non-operative treatment. You have to explain all the risks. You've seen in the presentations today, there are lots of complications can happen. This has to be explained to the patient quite clearly. A prehab is very important, so that helps in a very good post-op recovery of the patients. Graft choice is, I think, more of a patient and a surgeon choice. 95% is a surgeon choice, and the surgeon will say, this is the graft I use. However, I have few patients who will come to me and say, look, I want the BTB or only want the hamstrings, and that is fine. So I think in today's day and age, if you're an ACL reconstructive surgeon, you should be able to harvest all 3 grafts yourself and be prepared to use the fixation devices with them. But the best procedure will be the graft that you use most commonly and that most useful for you. Your intraoperative skills are important, that you put the graft in the right place. Otherwise, it won't work and it will fail. And post-op rehab is equally important for these patients. Goes without saying that always check the alignment of the patients before proceeding with any revision or ACL reconstruction. And now, a lot of footballers have constitutional varus in both knees. And then if you do an osteotomy plus minus an ACL, when the ACL rupture, they will not get back to football. So you could discuss with them, leave them in varus and do their ACL reconstruction. And I think it works most of the time, but explain to them there is higher risk of re-rupture. Always examine the patients properly. You do your Lachmans and make sure it is the ACL you're reconstructing, and you shouldn't have any surprises when you turn up at theater. When you look at there's a PCL which is gone. A pivot shift is easily done in clinic. ACL rupture is a clinical diagnosis, and 95% you should be able to do a pivot shift in the clinic. And MRI is to confirm that and also look for meniscal and chondral injuries. This has been talked to before regarding the 8mm graft. I did find a paper from India, Chandigarh, and they also mention the same, because most papers are on Caucasian cadavers and Caucasian patients, and therefore you may have bigger graft size anyway. But lots of papers around the world now do say that 8mm graft is better for preventing failure. Dr. Kataria has mentioned this very eloquently, that you have to make sure your tibial tunnels and the femoral tunnels are in the correct place. So if you put the tunnels in the correct place, whichever graft you use really doesn't matter. And as long as the fixation is reasonably secure, the patient will have a good outcome. Always look at post-op x-rays to see how the patient's fixation devices are. Interestingly, in the BASC guidelines, routine post-op x-ray is not necessary, but I think it just tells you if there's any fixation failure. And you're always looking at that picture on your right, which shows an excellent graft. Post-op, I interested in this capsulotomy thing, but I will discuss this with Dr. Kataria later on. But that seems interesting, and analgesia is very important. Any type of cool therapy is good to reduce the swelling and therefore increase range of movement, and also the immediate static exercises. Crutches for a few weeks and the rehab is equally important. Now, how can you get them back to sport? Up to 50% of competitive athletes do not return to competitive sport. And it is the first 6 months after return to sport when the graft can fail. So it's basically 9 months, which we say is before returning to contact sports, and 3 months after that. So it's 9 to 12 months almost before they can return back to their original level of activity, which sometimes is difficult. This paper in the BMJ looked at 6 clinical discharge criteria before they say the patient can go back to sports. The single hop, triple hop, crossover hop, and the running T test. I do the single hop test in patients around 8-week stage.
I think there is disruption, isn't it?
Well,
Can you hear?
Yes, sir.
Mr.
It's got disconnected, is it?
Yes, sir.
Yes, sir.
I think maybe the net is poor. But he has thrown a lot of new points, Amit has. Especially giving the information from the Ligament Registry of United Kingdom. It has given a lot of insight about what is happening around the world.
So, Dr. Subra, if you allow me,
Yeah, please.
So in your practice, is there a defined subset for all inside?
No, I don't do all inside regularly. I do only for those pediatric population.
Okay.
Where you think you want to not to damage the growth plate. That's where I do all inside technique. Or in occasion case of PCL, I do it, but routinely I don't do all inside technique. I have done it for a few cases, and then I didn't become much fancy about it. I thought the routine. Already we are doing good. Why do you want to make it complicated?
Exactly. No, I was just wondering, since Dr. Amit is probably doing completely all inside, I wanted to have his mind, as to why he's doing, because it's almost like, to me, it's almost like switching over from a cruciate retaining to a cruciate sacrifice.
My standard fixation is suspensory fixation on the femoral side.
Exactly.
And screw fixation on the tibial side.
Right.
And the usual graft diameter is 8 to 9 mm.
Right, exactly.
Mostly around, if they are athletes or sports people, I definitely try to get 9 mm.
Okay.
Conventional civilian population is 8 mm.
Okay.
How about your practice? Same.
So for the last 6 months, it was a learning curve for me to start with all inside. I'm gradually getting fond of it. I don't know why, but maybe you can say almost 25 to 30% cases now I try to do all inside. The remaining are the standard ACL. I still really cannot, promote or say very, very strongly about it. But I thought I'll ask Dr. Amit what does he's doing completely.
Amit is back now. Amit, sorry, we got cut off suddenly. I think there was an issue with the net. Amit, can you hear us?
Where did I cut off? Right at the first slide, is it?
Yes, I think, your slide was like almost we're coming to near to the end, I think. It looked
okay. That's fine.
Just last 2 or 3 slides.
Okay, well, that's fine. So I just had the last, yes, I think the all inside, Dr. Kataria, I think is quite good. It has few advantages, but one has to remember that most devices are, it's commercial bias. And you have to remember what you can use is best in your hands, rather than being pushed by literature and by companies that this is the best. So I think, like you have shown very nicely, use the graft properly, fix it nicely. And even if an old technique works transtable in your hands, stick to it, don't change just for changing it. But I've been using it for so long. I think it's just much better for me. Its graft preparation is better. I have only about 20 millimeters on both sides and have a very thick graft. Whether that's required or not, I don't know.
And you're not using hamstring anymore, is it? Amit?
So some patients, I use it when if patients want it. So, like ballet dancers and sprinters, I don't use hamstrings. Patients, otherwise, I'm tending to use primary quads tendon. That would be my first choice at the moment.
If in case using hamstring 4-strand or 6-strand?
It's a single semi-T, whatever strand it comes to. So it could be from 4.5 to 5 to 6. And you've taken that extra periosteal layer also helps to make it. So minimum size will be 8.5.
Prajwal, you have a question?
Sir, what does this say on Verona's longest graft?
So I have no experience. I know you use it in India, so I have no experience with that. Sorry. I will use because I'm happy to use a hamstrings from the other knee or even a quads tendon from the other knee. That's so there are 6 grafts around the knee: hamstrings, BTB, quads, plus the other knee, and it doesn't damage the other knee. In fact, Don Shelbourne used to use the BTB from the other knee in his first 100 patients because the risk of rupture of the ACL in the contralateral knee is higher.
So, Prajwal, peroneus I have been using, you used for more than around 20 cases now, nearly. So, this is only used for those cases where we are not able to harvest other grafts.
Okay, sir.
So, like revision scenario, or where you have multi-ligament injury, where you need another graft on top of routine grafts, and I am using it. But I have not seen any clinical consequence of the foot weakness.
Foot weakness.
And we have started a biomechanical study, which is not completed yet, about looking for the any evidence of eversion weakness. But clinically, they are looking okay only. We not have any problem. And literature also supporting that. So we can keep that as another choice of graft when they don't have protein grafts.
Okay, sir.
Himanshu, your experience about peroneus?
Yeah, so exactly, I am using peroneus primarily in a revision scenario, and where you're looking at a multi-ligament. The classical indications for that, not as a routine at all.
Okay, sir.
So if I can ask one question, if you allow, Dr. Subramanian.
Yes, please. Very welcome.
So I was just wondering your thoughts, Dr. Amit's thoughts on if you're looking at, say, a 25, 30-year-old male who is probably a recreational sports person, and he comes to you with a violent pivot on your examination. How would you modify your ACL technique in such a scenario?
Do you want to answer first, Subra?
I will. What actually Himanshu is trying to tell is instability even in just normal walking, not the pivoting, just normal walking. So gross instability, that kind of scenario.
Exactly.
I usually try to add up an ALL on top of doing a conventional ACL.
Even if the ALL is shown to be intact on an MRI, you would still do something about that corner?
Yes, that's what I have done.
Okay.
Because there is some, maybe ALL is stretched out. They may not be ruptured. They might have stretched out. So add up ALL on those kind of patients. But the technique will not differ. Maybe I'll use the same hamstring 9 mm graft, not the 8 mm, definitely 9 or more than that. Okay, and use ALL on top of that.
So any
I think in these patients, you have to be careful whether they have hyperlaxity. That's one thing you have to look at, whether there's hyperlaxity patients, and therefore examine the other knee, make sure that's fine. Also rule out your posteromedial and posterolateral injuries, because that may be causing the pivot shift. And so for younger patients, if I'm doing an ACL in less than 20 years old or 15 years old, and with high pivot shift, like you've mentioned, I will do a lateral tenodesis using a strip of the ITB under the LCL and fixing it back. I think that is shown in NF evidence that you need that to prevent the pivot shift, and you slow down the rehab.
And what is your, what do you do, Himanshu?
I have, as you mentioned, I would actually prefer something like an extra-articular tenodesis, and maybe probably a change of a graft choice, probably switch over to BTB.
BTB.
Exactly, yeah. But again, there is so much of literature which says that when you're looking at a hyperlax individual, is it wise to give him a knee which is back into hyperextension, or is it wise to give him a knee which is in neutral position? I don't know what's the take. You have a left knee which is hyperlax. You have an ACL injured knee which you now give it in a neutral position. Despite quite a few years, I'm pretty confused about this aspect. So
it becomes an issue, especially if you're operating on young female patients. Especially in UK or in India as well. They're wearing shorts and skirts, and the one leg will go hyperextension and one leg will not go, and they will not thank you for that. So I think if you have an hyperextension, fix the graft in hyperextension, because that's what that knee is made for it. And maybe I would use an internal brace of a fiber tape initially for a few months just to give that extra stability. And I think these cases, you just have to decide on table what you're going to do. Graft choice to BTB definitely will. If they're hyperlax, their collagen is already bad, and they're using their own graft again. So that's why use of an internal brace, fiber tape for a few months may be better.
Right.
Amit, have you used internal brace often, or you're using?
Yeah, so again, it's the height. So I've
Very
used
correct.
it, stopped it, all this comes along. Selective patients, and again with, I think the lateral tenodesis works better than the internal brace.
I think biological is better. Yeah.
Because internal brace will, yeah. And, it just increases the cost of the surgery as well if you use more devices.
Just interesting to know about, I think you started doing all inside recently, isn't it? Maybe a few years' time. Before that, you were doing different technique. I guess you were doing routine conventional suspensory fixation, or what we were doing before. And have you seen any difference in complication rate or same complication rate from previous technique and current technique?
For me?
Yeah, for you only. I mean, sorry.
So now all inside I've been using since 2012, and I've so for a long time now. The complications only when I change the position of the femoral tunnel. I think rest is fine. There has been no problem with that. People say you have less bleeding or on the tibial side. Definitely that helps. And I think you just need to have a good graft preparation at that time, but no difference in complications apart from the all inside to other hybrid methods. Sorry, what do you use, Subramanian?
My routine fixation is suspensory fixation on the femoral side and screw for the interference screw for the tibial side. Standard graft diameter is 8 or 9 mm. I used to put more 8 in the past, now we've gone to 9 now. And so what I do is hamstring graft, triple the semitendinosus, residues will be double. So it will be 5-strand graft. So put all things with the monocryl, put everything with the monocryl together and use that one. And button will be usually 15 or 20 mm. If you are using tight rope, that's different. So again, cost factor plays up here. Tight rope is a little expensive here. So I think in Delhi, how is you are using tight rope? I guess, huh?
Yeah, we are using tightrope. We are using ProCinch. We are using 2-3 companies. So mostly we prefer adjustable loops. I definitely, please.
Sorry, other reason to use just one tendon. I think leaves your gracilis if you want to use it for some other fixation. So you can have a graft, for your ALL or something. You can use it. So that does have the advantage. Yeah. You can leave it, or if you have an MCL injury grade 1. Yeah, because the hamstrings give some secondary stability. Leave the one hamstrings there. I think that helps. Sorry, Himanshu, you were saying?
Yeah, so I was, probably the only thinking I have is regarding the diameter of the graft. There was a time when I was being too ambitious, trying to get to 10. And my residents who were preparing the graft on the back table, when you actually start to put these 10 mm grafts into a knee, you might actually end up with some impingement. So I have actually stepped down to 9 mm, and I feel 8 to 9 mm seems to be pretty fine. 10 seems to be an overkill. And I don't know what's your take on that.
I certainly agree with what you're saying, because in few patients where I used 10 mm, I had troubles like arthrofibrosis, tunnel problems. And it's a big tunnel you are putting in it. You are making a big hole on a bone. So I felt really uncomfortable at those times. So similar thinking for me also. I don't want to go to 10 mm. Usually 9 mm is my threshold.
Yeah, it really depends on the knee itself. Once you, like most of us will scope the knee first to treat. And if you see a small notch, and you're trying to put a big 10 millimeter, it's not going to fit. It's just going to fill up. And that's cause, like you say, difference. And I don't know, there's a lot of studies which you look at MRI of the other knee to see what the size is. But again, you can't correlate that, unfortunately. So between 8.5, 9, I think is enough. Anything more is just unnecessary. And like Dr. Raj saw, all the grafts that we use are super strong than what the original ACL is.
Exactly.
What would you do in a revision ACL reconstruction, sir? Because you already have a loosening around the tunnel. So that time, how would it be an overstuffing?
In the revision,
it depends if the tunnels.
Go ahead. Amit, you please go ahead.
So, if your tunnels are in the correct position, then you could bone graft, come back later and do that 2-stage if required, because that's what should be done in basic cases. If you're able to do everything at the same time, then you can fill it up with double screws, put the graft and put interference screw as well, and then have your suspensory fixation. So you complete the tunnel at the same time.
Okay.
You make a measurement of diameter of the tunnel in all the cases where you're coming for revision. A nice CT scan will evaluate the diameter. Anything more than 12 mm, then you should think about doing graft. So because 12 mm is the maximum cutoff, you say.
It's just like CT scans you use for bony unions and fracture non-unions. It always is misleading. It doesn't tell you exactly what it is. So I think you should be prepared that you will just bone graft and come out. But once you debride everything, if you feel that it is possible to do the revision ACL at the same time. So I don't take the graft for the revision ACL till my tunnels are done. I think that's very important. So unless you know your tunnels are done, you shouldn't harvest the graft.
How early would you go in case of a tibia fracture? You've done a plating for a tibia fracture with an ACL injury. When would you go in and do an ACL reconstruction for them? Or would you just remove the screws at the end of 6 weeks, 8 weeks, and then go ahead and do an ACL reconstruction?
So this is a double injury, ACL and tibial fracture?
Yeah.
So, I think that needs to be then rehabbed till you're happy for the plate to be removed, or like you have said, just remove 2 screws. If it's a double injury and unless there's a meniscal injury, I think rehab them, get them to full range of movements, makes the knee stable, and then come back at a later date. It's very rare you'll have to do it both at the same stage because that patient may not require an ACL reconstruction.
I have one patient who has a segmental tibia fracture, with a global knee. So now he is still under union. The tibia has been nailed. So what should we do? He is walking with a brace right now. With the ONE support with 2 hinges, he is walking with it. So when would you prefer? Would you suggest that I do the ligament reconstruction?
Well, is the tibia going to heal? That is the first question. Is the tibia going to heal within the 6 months? Then your decision is made that wait for 6 months and do it. If it's going to be
6 months time, is it okay for the bone? Can we remove the nail, or should we bypass the nail and do?
I think then you remove the proximal locking screws and bypass the nail. I think it's a tibial nail. You should have enough space, and you go more medially on the tibia. Instead of coming in the center next to tibial tuberosity, you can go a bit more medially and come at a 45-50 degrees angle.
Both for ACL and the PCL, sir?
So the PCL comes lower down anyway. Lower PCL will come lower down. So the 2 locking screws may come in the way, and that's the only thing. And that might help in dynamizing for the tibia fracture anyway. So both can be done.
ACL will not be a problem, Prajwal, because entry side of the tibia nail is actually it won't come on the way at all. ACL won't be a problem. But PCL also you can get away. Not much use. Yeah.
Some nails have 3 or 4 screws proximally, and then that will be an issue. But if you have 2 screws, like Subra is saying, ACL will not be a problem. PCL you just see on your pre-op images where your tunnel is going to be, and that will help.
Okay, sir.
Excellent. I think good discussion. We are a little late also. At least in India, we are late. For you, it may be time still there for you, Amit.
It's getting dark now. So it's
getting
4
dark.
o'clock. Yeah.
Okay. Thank you very much, everyone, for giving a nice. I think all the 5 talks were excellent. And none of them were any substandard at all. They were all superb. And the experiences were very good. Thank you very much, Dr. Himanshu and Amit, both of you, very thank you. Bharath, thanks for preparing everything in the short time. Naveen, thank you for summarizing everything. And Prajwal, I think
thank you, sir.
Thank you. Thank
Thank
you.
you. Thank you for the
everyone
opportunity, sir.
participating in this. And thank OrthoTV also and also Sun Pharma Group. Thank you very much. Let's conclude the year.
Thank you. Bye-bye.
Thank you.
Excellent. Thank you very much.
Keep in touch.
Thank you.
We will.